And today I'm going to talk. Most people know I'm in charge of the autoimmune testing here at VGH, which is generally speaking the autoantibody test. And ambitiously, I thought that's great. I'll give everyone a big overview and I'll cover all the topics. And then I realized that to go through all of the autoimmune tests and paradigms that we do would be too long, too boring. And consequently, I've pared it down and I'm into two different parts. And today is going to be part one. I'm pleased to see that there's anatomic pathologists here because part one actually is relevant to the anatomic pathologists. Just to let you know, land acknowledgement, I recognize the sites occupied by VGH. Campus of UBC are on the traditional, ancestral, and unceded territories of the Coast Salish peoples, and that includes the territories of the Squamish, Tsleil-Waututh, and Musqueam nations. So I think that's important to recognize. People should think about that. And when I'm talking, I'm going to try and give you an overview. I want to make sure it's a sort of a practical session so that you know where you can get tests done that you may not be aware of, and especially for anatomic pathologists, if your clinician is sort of asking you what sort of test can I do to confirm a diagnosis, etc. So at the end of this session, high volume autoantibody tests available within BC, clinical indications for such tests, and the locations within BC that perform the tests. There are several individuals online that I think can help because I basically have put a broad overview of where their tests are available, but I may well ask people, are those tests actually performed at your hospital? Because over the last 2 or 3 years, Michelle in the Royal Columbian Hospital and various other sites in the interior, in the north, have now started to do some autoantibody testing, which is fantastic. It's obviously very helpful for their clinicians to be able to access those tests in a more expeditious way. So some of these tests they may or may not do. And as I say, the sort of the more generic ANA, etc., I won't be talking about today. I'll be talking about if I'm invited back. So I suppose it depends on how I do today. So conflict of interest. I am actually an employee here at VGH, and generally speaking, I don't receive monies from any companies, but the conflict of interest I do always include is the fact that I am a taxpayer, and I don't like money being spent on unnecessary tests. And those of you who are involved in autoimmune and autoantibody testing will know that there's a tremendous number of tests that are performed that there's no clinical indication for. And essentially, the thinking, it's a lot sort of, in many ways, it's like the old ESR. My patient is sick. I'm not really sure what it is. I'll do an ESR. If it's negative, then it's probably nothing serious. And a lot of the tests that are done at the autoantibody testing place at VGH include tests that are actually used to confirm a diagnosis. It's not to screen a general population, and that's very important. So obviously, just as a quick overview, I always think I should have been a chemist because chemistry, I like things, things go up, things go down. The immune system, basically you've got cells and extracellular substances, and disease of the immune system, it's either overactive, and within the overactive, it's either the cells are causing the problem, or substances such as autoantibodies, or a combination thereof, or it's an underactive system. The body can't protect itself. Maybe there's not enough particular type of cell, not enough particular type of complement, etc., or a combination thereof. And I'm not going to test anyone just yet as to the hypersensitivity reactions. I know Jeff would be able to cite them very quickly as type 1, type 2, type 3, type 4, and give you the examples of each. But they are an example of overactive immune systems, and some of the tests that we perform help to identify hypersensitive reactions. Autoimmune diseases, as a general rule, can either involve a specific organ or can involve multiple organs. And when they involve multiple organs, when I went to medical school, they were called connective tissue diseases. Before that, I think they were called rheumatologic diseases. Now we use the term systemic autoimmune rheumatic diseases. And that's the current name that we seem to have adopted. So why does the autoantibody testing exist at VGH and at the other sites? Well, autoimmune diseases may be associated with production of autoantibodies, and those autoantibodies are are antibodies that target antigens present in the body. And normally, everyone's aware that shouldn't occur. You should not have antibodies that target an antigen present in your body. There are various reasons why this occurs, why people will start to make antibodies, typically involving breakdown of structures, exposing epitopes that have not been previously exposed, molecular mimicry. So something you take causes a reaction, an immune reaction, and there's cross reactivity with something else in the body, etc. But basically, different autoantibodies targeting different antigens can also be helpful in identifying particular types of diseases. Interestingly, most autoantibodies that we test for are not thought to be pathogenic. Now, some of them are, and again, going back to medical school, I'm sure that if Tyler's still on there, I've only got Michelle, Jeff, Thomas, and Genevieve. I apologize because my screen right now, you're the only names I can see. So if I ask questions, you guys are in my my site. Oh, there's Tyler. So
I'm
Tyler,
here.
can you give me an example of a disease where the actual antibody is pathogenic?
Anti-GBM?
Anti-GBM, sure. Any others? How about thyroid disease?
Oh no.
Yeah, and this is
Hold on. I want to say either Graves or something like that. Hashimoto's or something. I'm blanking though.
I would like to see your differential diagnosis. So Graves, Hashimoto's, something like that. Correct. So Graves' disease is correct. Graves' disease is associated with the production of TSH receptor antibodies, and those antibodies will bind to the TSH receptor, causing release of thyroid hormone, etc. So that's a good example. Thank you, Tyler. Again, everyone here knows why we do lab tests, and these rules apply, or the reasons for testing apply here at the autoimmune testing lab. Generally speaking, it's for diagnosis, to help establish a diagnosis. Sometimes they will help to predict or assess severity of disease. Sometimes they're monitored for disease activity. That's not so often, but there are particular types of antibodies that we will follow, and to help guide therapy. So again, it's kind of interesting because I see that there's 40 people now and they're sort of right in the screen. I always enjoy autoantibody testing or antibody testing because it's actually very straightforward. And yet, I remember at medical school, it made absolutely no sense. All you had to remember was that anti-nuclear antibodies were associated with systemic autoimmune rheumatic diseases, and double-strand DNA was positive in lupus. And you basically had to learn that, but it didn't really make any sense. And once I got hired here at VGH, one of the things I was asked to do was to start, or to bring the autoantibody testing up to standards, because they were still using red cell agglutination. So they had sensitized sheep red cells that they look for agglutination process. And we don't do that anymore, okay? So the question is, obviously, the antibody of interest is circulating in your patient. We get serum, and serum is a very nice substance because it's cheap and easy. It's sort of like Dr. Nimmo. It's very cheap, very easy to get along with, and you don't have to do anything special with it. But then once you've got it, how do you actually identify it? And the beauty, and whoever came up with these tests, I really have to acknowledge them, because essentially what you do is you expose the serum to an antigen, and if there are antibodies that target that antigen, they will bind, right? Oh, wait a second. I'm locked. There we go. So you capture the antibody, and the question then is, well, how do you capture the antibody? We're a high throughput lab at VGH, so we do not take our own tissue and make things. One of the reasons you will see large variations in test results regarding sensitivity and specificity is because historically people would literally make their own test kits, where they would take tissue that they had available and make their own slides, etc. Where do you get the antigens from? We currently use tissue sections or purified antigens, both of which are supplied by manufacturers. In the case of the purified antigens, in ELISA, they're coded to the wells, the sides of the wells or the walls of the wells, and that allows for a very specific test. And currently, one advance that's been made over the last 10 years is attaching them to the surface of microspheres or beads, and essentially using a flow cytometer to come up with what we call multiplex testing, where you can do multiple antibody testing at the same time. And it literally is such a simple concept. You change the antigens, you change the test. So if you want to test for a patient who has primary biliary cholangitis, you simply expose their serum to something containing mitochondria. And if they have anti-mitochondrial antibodies, they will be detected. So it really, and if you suspect if you suspect pernicious anemia, then you can expose them to a section of stomach and see whether or not the parietal cells are being targeted, okay? Obviously, the second part is just like in the old days, when you took a picture and you had a negative, you have to make sure that you can actually see it. So once the antibody is being captured on that antigen, you have to identify that the antibody has been bound. If the antibody is bound to the antigen, it means that its fixed portion is sticking up, and you use a second antibody, again, supplied by manufacturers. And in the case of an indirect immunofluorescence, the second antibody has a fluorescent tag on it. And in the case of an ELISA, the second antibody has an enzyme that takes a colorless substrate and converts it to a colored product. Really simple. I mean, it really is very, the simplicity of the system is very appealing. Okay, so this is just an overview. Again, on the top, this would be your slides. So if you're doing something like an ANA by indirect immunofluorescence, if you're checking for ANCA by immunofluorescence, if you're checking for crithidia, double-strand DNA, you would use these slides. This patient is the source of this antibody, and then you use a second antibody supplied by the manufacturer. ELISA, in this case, the second antibody has an enzyme that converts a colorless substrate to a colored product. The beauty of that is it's automatable, right? So anything we can do in the lab to make things easier, more consistent, reduce tech time helps. And then multiplex, the final system, as I said, you actually have antigens on the surface of beads, and you take a flow cytometer, and thankfully here we're able to access the flow cytometry used in immunology, and it can be used to do this, and we just pass our specimens through and see what comes up. Okay, here you go, ANCA, indirect immunofluorescence. This is our little hors d'oeuvre for antiparietal cell antibodies and for mitochondria. There's stomach here. So from here to here is stomach. This is the smooth muscle of the stomach wall, and this is the actual epithelium. And the parietal cells here are lighting up, and they're lighting up here because of the mitochondria. And here are kidneys, and these are tubules, and within the tubules, cytoplasm are mitochondria. And so this is our antiparietal cell, anti-mitochondria, and in fact, anti-smooth muscle antibody test. It's an MSK slide is what we use. So again, I've already described that there can be specific autoimmune diseases. Tyler very kindly said Graves' disease. I've talked about primary biliary cholangitis. Another classic would be myasthenia gravis. Okay. High volume autoimmune testing in BC, part 1. So this is when we start to get into the nitty gritty. Okay. And I thought it would be more interesting if I sort of highlighted different people's approach to the diagnosis. So for example, here, Jeff, do you want to hazard a guess what the diagnosis is?
Acne.
Acne, excellent, okay. I will now go down a slide, and on my left is normal small bowel, and here, now what do you say?
Well, I'm guessing you're trying to show celiac disease.
Trying? Trying?
Yeah, no, celiac disease for sure.
Okay, so and Jeff actually is absolutely correct. What you see here is complete loss of the villi in this small bowel biopsy. I always think it looks like colon because you've got crypt elongation or crypt hyperplasia, loss of the villi, and a chronic inflammatory cell infiltrate. So it looks a lot like colon typically when I'm doing the sign out, I pick up a slide, I look, and I'm going, it says duodenum, but I'm looking at colon, and that's in someone with classic celiac disease. And then if we switch from clinical to anatomic to chemistry, and I'm not sure, or let's say heme path, if you're provided this result, what is the diagnosis? Michelle?
I was scared you were going to ask me, Mike, because I'm like, I don't know if we do that testing here. So
Well, that's good.
I don't think we do. I don't know. I don't know. Actually, it looks high.
Excellent. It is high, and that is the diagnosis. So celiac disease. So the three things that I want to emphasize here, and Michelle, you're absolutely right. And in fact, that was one of the questions I had for you, Michelle, was whether or not TTG testing is performed at the Royal Columbian Hospital or in Fraser, because I know a lot of it is done at Life Labs, and we do a significant amount for the hospitals, but I don't know if you guys actually do it.
I believe that ours is sent to Children's. I'm pretty sure about that. I don't know if Suzanne's here and she might remember. I don't think we do that in Fraser, from what I recall.
So
I have no clue. Ask biochemistry. I'm so bad at this, Mike. You cannot believe it.
Well,
that's why I'm here. That's why I'm listening and learning.
Well, there's a couple of things. One, I do this stuff all the time, and I just have to be honest. It's so boring to me because I just live and breathe the stuff. The questions I get daily, this, what, and I just can't think that would be interesting. But it's nice to hear Suzanne say that she's actually learning something. It also underscores a couple of things. One is, historically, these antibody tests or autoantibody tests were part of heme path. Okay, and at VGH, the autoimmune lab is part of hematopathology. However, chemistry, and I think in Children's Hospital, Suzanne, several of the tests are actually done in the chemistry division, and that is true at VGH as well. For example, TPO or anti-TPO antibodies for Hashimoto's thyroiditis are performed in the core lab, I believe, on a nephelometer. So it's not part of our lab, but it just shows the overlap. And to me, obviously, disease. Oh, sorry, got to get back onto there. Common disease number one is celiac disease, and it is a common disease. It's an immune reaction to eating gluten, protein present in grains, in genetically susceptible individuals. Where do you get gluten from? Wheat, barley, and rye. People who have celiac disease present with diarrhea, fatigue, weight loss, bloating, anemia. In children, it can lead to failure to thrive and other conditions. The skin lesions are dermatitis herpetiformis, and as Jeff said, it's difficult to just look at the skin and say that is diagnostic of dermatitis herpetiformis. Maybe Dr. Crawford would be able to make the diagnosis, but to us, we'd sort of say, no, we need to see biopsy and or serology. So at VGH, we perform, I'm a general pathologist. You can see my sort of blurred microscope beside me, and I look at GI biopsies. And to my mind, you should do a GI biopsy or a duodenal biopsy, small bowel biopsy, to confirm the diagnosis of celiac disease. But I will talk now, how do you test for celiac disease? At VGH and at Life Labs, I'm not sure if anyone from Life Labs is here, if Wes is here, but we test for serum IgA anti-tissue transglutaminase, okay? Interestingly, usually everyone just calls it TTG. They don't call it anti-TTG. So technically that's not right, because TTG is just tissue transglutaminase, and that's an enzyme. So technically it is anti-TTG, but everyone just says, what is the TTG? Where in BC is the test performed? Michelle's already indicated she's not sure if it's performed at Royal Columbian. I do know that it is performed here at VGH. It is definitely performed at Life Labs, and it's performed on the island for sure, okay? What test method is used? ELISA, and the system that we have here at VGH is not an ELISA system per se, it's enzyme-linked immunofluorescence assay, where instead of an enzyme being taking a substrate and converting it to a colored product, it actually binds, or there's a tag on it and it fluoresces. So it's kind of a combination between indirect immunofluorescence and ELISA. Okay, so Suzanne, what type of hypersensitivity reaction is celiac disease?
Don't ask me.
How about you choose someone? Can you see anyone else?
Can I ask a friend?
You can ask a friend, but
Good.
they might not think you're a friend if you ask them.
And I may not have any friends. Even
You
sadder.
wanna ask?
It's a type 2.
Type 2. Okay, so someone says type 2. Anyone else?
I vote type 4.
Type 4.
Type 4?
Ah, so type 4s are coming out of the woodwork now.
People
You
had
need-
enough time. People had enough time to Google it.
Hey, that's not fair. The answer is actually it's a type 4 hypersensitivity reaction.
Yeah.
Why? Because the small bowel villi, it's a destruction of the villi by the lymphocytes, and during that process, epitopes are exposed, including tissue transglutaminase, and therefore the antibodies are made. But it's not, the antibody itself is not pathogenic. Okay, so that's the current understanding. So my next question would be, can you actually be allergic to wheat? Eunice, how do you pronounce your name?
Yeah, my name is Eunice. Yeah, no,
Eunice.
yeah, you can be allergic to wheat, can you not?
Absolutely, but how would you present?
With anaphylaxis. It's an IgE mediated process.
So it's IgE mediated, absolutely correct. And typically what happens is as soon as celiac disease, it actually takes time to develop celiac disease. It's not that instantaneously you take a piece of bread. Let's assume you've been on a gluten-free diet and you take a bread and immediately all your villi are sloughed, and you know it's a cell-mediated destruction of the villi with remodeling, and that takes time, right? It's like your TB skin test. If they still do that, I don't know. But you had to read it at what, 48 to 72 hours, because the cells, it's again cell mediated and the cells have to migrate into that area. Whereas if you have an actual allergy to wheat, when you first touch your lips and stuff, you would start to have a tingling sensation. I'm not sure if you could actually have an anaphylactic reaction, presumably. I mean, never say never in medicine, but there are individuals who are actually allergic to wheat. There was someone I used to train, someone who used to train me. I didn't used to train them. And they told me that they had celiac disease. And I said, you know, how do you have the diagnosis? And she essentially told me that her mom had told her for some reason. But what she described was actually an allergy. She'd never had her TTG done or anything like that. But TTG is not, or sorry, celiac disease is not a type 1 hypersensitive reaction. It's a type 4 cell mediated. And Suzanne, I want to bring you back into the fold here. Do you know where, I believe this is true, and maybe I'm just making this up, where was it first diagnosed? And how
In
was
Holland. It's always in Holland.
And do you know why?
Do I know why? Because we eat too much bread and cheese?
No, it actually, so I think the first record or the first descriptions were back in the 1916s to 20s sort of thing. And then not much was known about it. And I believe, you can check on Google and see if I'm wrong about this. Maybe I'm just talking through my hat. During World War II, the Dutch, the wheat was diverted to Germany, and there was no bread to eat in Holland. And people noticed, physicians, I assume, that some of their patients got better. And that was because they did. And then at the end of the war, when wheat was reintroduced, individuals would get sick. So that's my understanding. Again, I might be talking through my hat, but
Well, it is true that we only ate potatoes during the war, so it's possible.
So obviously, if you're only eating potatoes, if you have celiac disease, then you're not going to have the gluten-sensitive enteropathy. So interesting, and obviously, a lot of work has been done since that time, and they've identified the various types of, associations, not just in wheat, but also in rye and to a certain extent barley. Okay, so what are the issues with testing? And again, I'm not sure if anyone's here from the lab agency, but this is something I have to confirm. Testing detects IgA TTG. So obviously there are different types of immunoglobulins, and for some reason, I have to admit, I don't know why, other than IgA is the type of immunoglobulin present in secretions, they've always tested for IgA TTG. And there's a big problem with that because if you're immunodeficient, and again, my understanding is that the most common inherited abnormality or deficiency of the immune system is IgA deficiency. If you're IgA deficient, you will have a negative TTG test if it's testing for IgA TTG. So the issue then becomes, well, does that mean you're more or less likely to have, if you have IgA deficiency, are you actually more or less likely to have celiac disease? And in fact, patients with IgA deficiency have an increased risk of celiac disease. Back, I don't know when it was put into place, the government has said you cannot co-order IgA levels with tissue transglutaminase antibody testing. The reason being, everyone just automatically do it, so you're going to increase the costs, going back to my, I don't want to spend money on unnecessary tests. And I don't know if Vilt is on the line, but you can do IgA levels, obviously. And in someone you suspect of having celiac disease, who has a really, like a flat negative TTG, you can actually do an IgA level and add that on later as a secondary test. But again, in order to contain costs, currently my understanding is you cannot co-order IgA levels with TTGs. The solution other than ordering an IgA level is to test for IgG TTG. I'm not aware of any testing for that in British Columbia. Michelle, you were just about to unmute and say something.
Oh, you're very observant, Mike. That's like, no, I inadvertently did that, but yes, since you had a moment, I can confirm, yes, that we do send our testing for anti-TTG to Children's from Fraser.
Yeah. Perfect, excellent. So yeah, so careful, I do watch my screen, but again, I've only got about 5 people I can see what they're up to. So you can test for IgG TTG, the testing does exist. I'm not aware that it's performed in British Columbia. And so that would be a send out test. There is a test, a more recently developed test, where they have, the old test for celiac disease was anti-gliadin antibodies. And they identified different types of antibodies that were more sensitive and more specific. And that's why we don't do anti-gliadin. However, there is a modified gliadin peptide called a deamidated gliadin peptide that is a more recently developed test, and it is an IgG-based test, and that's available at Royal Jubilee Hospital. So sometimes I would get calls from individuals up the coast saying, I have a patient who I really suspect has celiac disease, but the IgA TTG has come back negative. Is there anywhere I can get deamidated gliadin peptide testing performed? And the answer is yes, it is performed within British Columbia, and it's performed at Royal Jubilee Hospital. In the pediatric population, and working at VGH, clearly I don't deal with the pediatric population, but there are guidelines, EULAR guidelines and other guidelines where they want to avoid exposing children to having biopsies if they can. And they come up with these guidelines that will establish a high probability of celiac disease without actually doing a biopsy. And I know Jeff and Dimitri and whoever's on who are anatomic pathologists, I just, to me, you have to have a biopsy. It's unfortunate, but to me, it absolutely is essential. The first time that they would go about diagnosing celiac disease, 30 years ago, whatever, I believe they would take a biopsy and show that it was abnormal. They would place the patient on a gluten-free diet, rebiopsy, and confirm that it had gone back to normal, or it was now normal, and then give them a gluten challenge and confirm that it went back to abnormal again. So to me, that's torture. I think our current system of a serum TTG or equivalent in combination with a duodenal biopsy is what I personally would recommend. But these guidelines for pediatrics recommend serologic testing without necessarily having to biopsy, and they incorporate these anti-endomysial antibodies, which preceded the tissue transglutaminase biopsies. And it is an indirect immunofluorescence test performed on monkey esophagus. I'm not aware of it being performed within British Columbia. And again, that would be a send out test. It seems to me, I don't know within Children's Hospital, Suzanne, Jeff, do you know if people send it out?
I don't.
I don't know.
Okay, okay. And again, I think, Suzanne, at Children's Hospital, it's chemistry test, right? Like TTG is within chemistry?
Yeah, I don't know if Wilt is on the line, but I believe it is EMA we do for like that's hereditary spherocytosis for us.
I beg your pardon?
EMA is hereditary spherocytosis for us. That's a whole different disease. So EMA testing is confusing for us.
Oh, okay. Because it's the same, what do you call it? It's the same abbreviation.
Yeah.
Yeah, yeah.
But
Okay.
I don't know anything about anti-endomysial antibodies.
Exactly. Yeah. So again, just another serologic test. And you can see there's an evolution over time, anti-gliadin antibodies back in the 50s, 60s, anti-endomysial antibodies based on indirect immunofluorescence. Trouble with indirect immunofluorescence, it's very time consuming, a lot of tech time, etc. Subjective, because one person's fluorescence is another person's negative. So you have to get consistency. And again, the introduction of these semi-quantitative ELISA tests allow it to be automatable. There's automatic readers for the colored product, and you get a result. It is interesting from my perspective because let's go back to the anti-GBM antibodies. I've been called, and this was 20 years ago, I think, and we were doing it by an ELISA, and normal was less than 20. And the clinician called me because they were plasmapheresing this individual with or for Goodpasture's disease. And they said, yeah, it's 19, but we want to get to 0. And unfortunately, that clearly demonstrates a lack of understanding of lab testing and the concept of background noise. We provide in ELISA, we provide semi-quantitative results. We would like to provide them as negative, low positive, moderate positive, strong positive, but they like numbers. And, the concept that a positive value of 100 is somehow different from 80. Again, I can pepper this with all kinds of little stories, but I find, again, I tend to go overtime and people don't like that. So I will try and keep my stories to a minimum. But yeah, that's one of the things you can do is anti-endomysial antibodies, and we will send it out if there's a clinical indication for it. Again, what if you have an equivocal anti-TTG, so you're not IgA deficient, and the biopsy is sort of equivocal as well? Well, as my original definition said, it's in genetically susceptible individuals, and 97% or greater of patients with celiac disease either have a DQ2 or DQ8 HLA haplotype. And so that screening is possible. So if an individual wants to know whether or not their symptoms are related, presumably if they are negative for DQ2, DQ8, the chances that they have celiac disease would be extremely low. And I do know that the immunology lab at Vancouver General Hospital, not the autoimmune lab, but the immunology lab does perform DQ2 and DQ8 antibody testing. So again, that's just another method. If a patient really suspects, but their testing is coming back sort of equivocal, the biopsy is equivocal, the clinician can offer that. Refractory sprue is a disease where the diagnosis is celiac disease, but it's not responding to a gluten-free diet. The most common cause of failure to respond to a gluten-free diet would be you're not actually on a gluten-free diet. Either the patient themselves are like me and find it hard to stick to a diet, or the food is contaminated with gluten. It is extremely difficult. You'll see it when you go and shop for food. It will say may contain gluten. It is extremely difficult to identify foods that are free of gluten because a lot of food processing occurs in a situation where there's cross-contamination and gluten may get into it. There are definitely stores throughout the Lower Mainland that are providing gluten-free, certified gluten-free products. But even in that situation, there are people who are on a diet, for sure it does not contain gluten, but they're not really responding. And what they're trying to do is come up with a method. So the gastroenterologists have contacted St. Paul's and there's sort of new methods to help identify, is this truly refractory celiac disease? One of the concepts is flow cytometry for celiac disease. The concept is the same as if you have a person with a gastric biopsy that shows a low-grade malt lymphoma. Some people will take biopsies in saline or saline-soaked gauze. They will disaggregate the specimen and run it through a flow cytometer to check for the presence of tonality in the case of maltoma. In the case of celiac disease, you can do the same thing. You can obtain a biopsy. Obviously, you can't obtain it in formalin because the formalin is going to cross-link all the antigens, and you're not going to be able to flow it through a flow cytometer, but you'd have to obtain a biopsy on a saline-soaked gauze. And there's some suggestion that that is a very useful adjunct in patients who are not responding well. I'm not aware of anywhere within British Columbia that's performing or even thinking about performing that test. Obviously, it's not something we could send out because the viability of the tissue on saline-soaked gauze, you have to be able to process the tissue relatively quickly in order to prevent the lymphocytes from spoiling, okay? In addition, and this always makes sense to me, there's got to be other causes other than gluten for small bowel damage. And there are some suggestions of so-called anti-enterocyte and anti-goblet cell antibody testing to identify atypical cases of autoimmune gastroenteropathies. Again, not available in British Columbia, but it is something that we might possibly look at. Any questions about celiac disease? And but I would say that that is probably our biggest test that we perform because celiac disease, you saw the symptoms, you know, bit of diarrhea, bloating, very non-specific symptoms. One of the things we would get biopsies for rather than an actual TTG. So the TTG would be ordered relatively quickly, I think, in a patient who had non-specific abdominal symptoms. But for us, a very common scenario would be a patient with anemia and we get a small bowel biopsy because they're looking for celiac disease, right? The celiac disease is going to impair the iron uptake. And we typically get the twin pack of a duodenal biopsy and a stomach biopsy checking for Helicobacter gastritis, causing sort of low-grade bleeding. And that essentially is the history. Anemia, query, celiac disease, query, gastritis. Any questions on celiac disease? Is that what you thought I was going to talk about? Doug Morrison, how are you doing? Doug.
Good, I'm good. So, sorry, Mike. I was actually afraid to ask a question because I thought you might ask me one. But
you're on to me, Doug. The best way is make people scared, and then they're not going to ask anything. But you clearly didn't you weren't dissuaded from it.
Oh, it scared me. But I wanted to ask you a question. If
sure,
there is a connection with this anti-TTG testing and transfusion medicine. So do you know why we're particularly interested in it?
I do not know that. Why are you particularly interested in it?
Well, and you touched on this, and it's because the antibody that's being tested for is an IgA. And so when, of course, if you described if the test is completely negative, that's often a way that patients who are individuals who are IgA deficient are identified. And IgA deficiency alone doesn't necessarily change your transfusion components that you receive, but we have had occasions where individuals who've been identified in this way actually also demonstrate anti-IgA antibodies, and their transfusion management is a little more complicated. So interesting.
That's very interesting. Excellent.
Mike?
ZR?
Yes, thanks, Mike. I see more people that identify as gluten intolerant. And my question is that something that correlates with the level of autoantibodies that you measure, or those are subclinical people that we can never find out unless they go on an elimination diet?
That's an excellent question. I don't know what the definition of gluten intolerant is. And again, I would have to look that up. But, you know, celiac disease itself is a serious disease, causes lots of symptomatology associated with various conditions. But I think sometimes people just do have this idea that they are gluten sensitive, and without actual what we would consider traditional confirmation. So whether that's what people are calling gluten intolerance, I'm not sure. And I do know that there are various other areas. For example, naturopaths have asked me, do we test for specific types of immunoglobulin G, like, you know, to see, because there might be a subclassification. And again, my testing here, it's just IgA, and I don't get into the clinical side of it from that perspective. That is definitely a more clinical question. So I can't answer that, sorry.
So Mike, it's Cedric here.
Oh, Cedric.
Can you hear me? Fine, I think I introduced this test way back with Dana's help. But anyway, one area of interest I got into were people who had unexplained iron deficiency anemia. And these were healthy people. I mean, they weren't classic celiac cases. And they would present with iron deficiency anemia with no obvious blood loss. And they'd have a high TTG, and I used to put them on a gluten-free diet, and things improved. So it is one of the uses of TTG, unexplained iron deficiency anemia.
Yeah, and you know, obviously, if you've got an unexplained iron deficiency anemia and maybe some abdominal issues, or I guess isolated without abdominal issues, then maybe the patient is not that bothered by the issues. And that's certainly, as I say, Cedric, that's definitely one of the indications we get for our GI biopsies. So gastric and duodenum. Eunice?
Oh, yeah, I just had a quick question. So yeah, iron deficiency sometimes, I'm a hematologist, so sometimes we see iron deficiency in the context of celiac. The other thing we see, though, is hyposplenic changes in the context of celiac. And I never had a good explanation as to why that is.
Oh, did you look it up? Can you tell us?
I tried. I just couldn't find a source that truly explained why.
That's an excellent question. I don't know the mechanism of that. And it's interesting to hear everyone talk. I mean, as Doug Morrison said, you know, this lack of a TTG issue raises issues regarding transfusion medicine. Cedric's commenting on the iron deficiency anemia and, you know, going on a gluten-free diet and seeing resolution of that. Splenism, very interesting. Did you say hypo or hyper?
It causes hyposplenism.
Yeah, hyposplenism.
You get how jolly bodies and so on. But a lot of other causes of malabsorption will cause hypersplenism. Again, I don't know the mechanism.
Okay, thanks, Cedric. And again, there are neurologic changes as well, less common, but I actually was involved in a paper with someone involving looking to see TTG levels in I can't remember if it was ataxia. It's a long time ago now, but again, there are neurologic. So very interesting, this sort of interaction between this constituent in the diet and these various manifestations within the body. So, and that is one of the interesting things about autoimmune diseases is the protein manifestations that come forward. And something as simple as wheat. And obviously, if you do have celiac disease, it's extremely difficult to try and only eat something without gluten in it because it is so pervasive. Okay, that was the first disease. How are we doing for time? Okay, we've got 12 minutes. I'll try and make this one a little quicker. Go ahead, Michelle.
Mike, there's also some comments in the chat relevant to what was just being discussed.
Oh, so you assume that I'm competent of looking at chat. Let's see here. Okay, Jackie Kwan correctly identified acetylcholine receptor antibodies. REHM2 type 4, excellent. Audi, what did Audi say? Type 4, yes. Linda, TB skin test still being done. Thank you, Linda. It's good to know. anti-EMA is sent to Alberta. Okay, that's good to know. It definitely is a send out test. We don't perform it here. We had a lot of requests for IgA antibody testing, CBS, celiac testing. We now restrict to patients who have had a proven transfusion reaction. Interesting. Gluten intolerance is when you get sick after eating gluten. You might feel bloated, gassy, or tired. It's a protein found in many, blah, blah, blah. Gluten is also called non-celiac gluten sensitivity. It's not the same about our gluten intolerant. Cleveland Clinic. Thanks, Maziar. There we go. Okay, thanks for the comments. At least we're getting people talking. It's a high volume test, and I think there are many indications for the testing. It's not a perfect test. There are definite drawbacks to the test. And one of my questions is, not to you guys, but just in general, is why we don't do an IgG. And it may be that it's a more difficult test to perform. Maybe the sensitivity is not as good. But to me, you obviously would get a better response if the IgG was tested for. Anyways, I'll just go on. And I've just got one more disease to talk about, and it's a less involved disease because I know less about it. But this is more of a systemic autoimmune diseases, which are a group of diseases that obviously have systemic manifestations, old names, the connective tissue disease I talked about before. They may also have autoantibodies present, and testing for autoantibodies obviously will help to identify whether or not someone has an autoimmune disease. And this is, the classic tests are an anti-nuclear antibody test and rheumatoid factor. There's no way I have time to talk about anti-nuclear antibody testing today, so I'm not going to do that. But let's start off with, whenever I move the box, I have to click back onto my PowerPoint. They're relatively uncommon, but I tell you, there's a lot of tests that get performed, and that's because these tests are not meant to be screens, but are used as screens quite frequently, partly because systemic autoimmune rheumatic diseases are so difficult to diagnose because people are not necessarily well trained, they're not common, and the way they present is a sort of a non-specific type of change, often confused with or presenting similar to an infection, something like that. So we'll go back to the same process. And if there's a clinician, Cedric, diagnosis. We lost Cedric. Okay, I'll go to
rheumatoid arthritis.
Oh, Tyler, the hematopathologist coming through. Excellent. So that obviously fingers with the changes of autoimmune gastritis, rheumatoid arthritis. This is for the anatomic pathologist. What's anyone know?
Rheumatoid nodule?
Rheumatoid nodule. So this is sort of fibrinoid necrosis in the center here with palisading histiocytes around it. And it's called a rheumatoid nodule. And you classically see them on the adjacent to the elbows, etc., ankles. Or if we have any chemists here, a rheumatoid factor greater than 50. So the second test I want to talk about is in fact rheumatoid arthritis. And this is the ACR criteria for diagnosing rheumatoid arthritis. And you can see the lab plays a very important role. And both with CRP levels and rheumatoid factor and the associated test, CCP. So rheumatoid factor first, what is it? Interesting enough, it's actually an autoantibody, IgM, that targets the fixed portion. So the antigen specificity is the fixed portion of IgG. And it's traditionally been used to test for rheumatoid arthritis because it occurs in up to 80% of patients with rheumatoid arthritis. And so if you have the clinical features of rheumatoid arthritis, it helps to support the diagnosis. So this is a diagram off the web, and it's a pentamer, so IgM. Sometimes you can get an IgG type of rheumatoid factor, but the majority by far are IgM. And so it's a pentamer, and the binding site binds the fixed portion of IgG, okay? And the limitations of rheumatoid factor are 40% of rheumatoid arthritis can be rheumatoid factor negative early in disease. rheumatoid factor can be positive in a lot of other diseases and can be positive in normal individuals. Where is rheumatoid factor performed? It's performed at Life Labs, obviously. It's performed at hospital labs. This includes here at VGH. It's not part of the autoimmune testing lab here at VGH. It's actually performed in the main lab by nephelometry. I'm assuming, Michelle, you do rheumatoid factor there?
Yes, yeah.
And what method do you use?
That I'm not 100% sure about. Yeah,
No
not
problem.
yet.
Because I know at Children's Hospital, they actually use latex agglutination. And so there are different types of methods. And, we use a nephelometer, and the nephelometer, I believe, does C3, C4, CRP, et cetera. And so it's very easy to perform. And what the trouble with rheumatoid factor, because of the lack of specificity, they analyzed the joint fluid of patients with rheumatoid arthritis, and they found breakdown products in the joint fluid that contain sort of keratin, various other substrates that had a strange amino acid in it, and these antibodies formed to it, but they could not identify the antibodies in serum. So it was, anti-keratin, a couple of other ones, fibrillin, I think. But what they identified and they were able to do was to create a synthetic peptide called CCP, CCP standing for cyclic citrullinated peptide. And citrulline is this unusual amino acid that is present in the peptides in the joints. And they came up with this test where they created a synthetic one and were actually able to use it to test patients' serum. So why test for anti-CCP antibodies if you've got a rheumatoid factor? A couple of reasons. One, rheumatoid factor tends to be positive in infectious diseases, whereas CCP helps. It shouldn't be positive in infectious diseases. It can be, but it's not as common. Patients with rheumatoid arthritis, it's actually not as sensitive as rheumatoid factor, but the specificity is much better. It also suggests, if you're positive for anti-CCP, it suggests that you're going to have a more aggressive type of disease. It's also positive earlier. Interesting enough, again, I'm not sure if this is back in Holland, Suzanne. They're ingenious there. They analyzed blood bank material that was, that went back decades. And by analyzing patients' blood that was in storage, they were able to identify that 20 years or a certain number of years preceding the onset of rheumatoid arthritis, there were antibodies to CCP present in their blood. Generally speaking, I would say that probably rheumatoid factor and anti-CCP are both useful because they don't necessarily overlap, and there's possibly subsets of rheumatoid arthritis. I've already said where they're being performed. For anti-cyclic citrullinated peptide, Life Labs performs it. We perform it. It is a high volume test. We do it by ELISA or ELIA here. There's some question as to who can actually order it. When it was initially introduced back in the early 2000s, it was felt that only rheumatologists could order it. I don't think there is the same restriction. We certainly, keep this to yourselves. We certainly, if we get an order for it, do the test, but don't get paid for it. So I don't want to get in trouble with administration, but we don't check to see, is the ordering physician a rheumatologist or a family physician? We just do the test, and then of course it's sent to MSP, and they check there. And if the ordering physician is not a rheumatologist, we don't get paid for it. I don't know that the restrictions are still like that, but CCP again is a very very common test that we have ordered here at VGH. And currently we're actually helping out Life Labs. I think they had an issue with supply, which is another thing I want to stress is I think in autoimmune testing or autoantibody testing, I like to create a collaborative and collegial type of environment. And so, we were contacted by Life Labs, by Wes, and he said, we're actually having supply issues with our kits for the anti-CCP. Do you mind doing them? And it's like, yeah, of course, we'll help out, and hopefully they will get supplies in the near future. But these sort of things do happen. And I guess the last question I have Anyone want to tell me what this chemical molecule is? Not Tyler. 'cause I think
Yeah,
Tyler-
I won't give it away.
Okay. Suzanne, any idea?
You're really picking on me and you don't support my comment that I put in the chat.
Oh,
It's-
Because I feel like I cannot answer any of your
It's a joke.
questions.
Oh, Suzanne,
It's a joke.
this is a Ferris wheel.
Oh, that's cute.
You like that?
I like
What-
that.
What did you put in the chat? You assume
Dutch
I'm